Oh, okay. Eric reminds me that the hour has arrived. I've called the meeting to order. Let's have
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Jessica, can we have a roll call?
Yes. Hi, everybody. Just a reminder before I do roll call, whenever you need to ask a question or speak, just make sure you guys have the mic on green and that you're talking close and you can hear your voice like this echoing through. That just makes sure that everybody online and everybody who is watching on YouTube can hear you. Okay. Glenn Bailey? Dr. Johnson?
Yes.
Commissioner Kells? Commissioner Bertling?
Yes.
Dr.
Yes.
Peggy Cavala? Chairman Fletcher?
Yes. Okay, public comments? We have Commissioner Horn here. Thank you for coming.
I'd just like to say real quick, sorry I missed your last few meetings. You guys changed your schedule around, and I wasn't able to make it until today. And I got my schedule all worked out, so I should be able to make it going forward.
Well, we appreciate it. I know you and I had spoken about marketing, and you had some ideas on that. And I want to hear from you. But let's hear, if you don't mind, let's hear from Dr. Pinnock. Let's have a board discussion to generate what direction we're going in, because I think how we would market that sort of follows from what it is you're going to do. So let's not put the cart before the horse. I guess that's what I'm saying. But do you have any comments to make?
No,
Okay. All right, consent agenda?
Thank you, Chairman. Not a whole lot in the consent agenda this month. We didn't have new grants or contracts come through this month. The packet does continue to have information for consumption on different areas of where the programs have been working and our fiscal staff. That is.
Wow. Okay, Finance Committee, Glenn?
Thank you, Mr. Chairman. Finance Committee, so, and thank you. Yes, the Finance Committee, we got together just a week ago.
Yeah, last week.
Last Friday, and it was an excellent overview and presentation by Christine, our physical part of the health district here. And it was very educational for us to see the different definitions, the things that we need to become familiar with as we go through the whole physical and the finances, et cetera, et cetera. And we also discussed the building maintenance issues that are going to be hitting the district. The 27th pay period will hit fiscal year 28, which needs to be planned for. And also any potential changes in the clinic services that are provided, that we would need to be able to fund any additional employees, various things like that. So it was a good background overview. I really appreciated Steve and Eric's consultation and advice on that. Gave us some good food for thought. And we will continue to meet on a regular basis as things go forward to meet deadlines, to make sure that we consider all the options. So,
Okay, well, thank you. The only thing I would add to that is a decision was made, and Christine has agreed to participate here, but it's going to be probably a phase-in period of time. And that is when we present the financials, it's going to be in a context where you will have a multi-year progression that you can look at.
Right.
So right now, we have, budget to actual, and we may even have last year. But moving forward, we're going to have multiple years so that visually speaking, you can see trend lines. And it's easier to pick up on trend lines. But Christine said this is not going to happen in 24 hours. This is a lot of reformatting of data, and it'll be an investment on her part. But she was very gracious to agree to formatting the financial data in that. And I've been on boards historically where financials were presented that way. And it's really, I think it's very useful to see trend lines multiple years. Anyway, that's the only thing I have to add. Do any of you have any questions regarding financials? Christine, do you have any additions that you want to make? Oh, right, yeah. No, I got it. It won't process. Right, right. I guess the last comment I would make, which is more political in nature, so we're all aware of what's going on with Medicaid fraud in Minnesota. And that phenomenon is spreading to the rest of the country. And Idaho is not exempt. We're at a number of articles now. There is even preliminary legislation being advanced to examine closely the potential for Medicaid fraud in this state. Eric has reminded us on many occasions that our budget is critically dependent on the largesse of the government. And if there, with all of this legalization of Medicaid fraud, there could be budgetary turbulence. So just keep that in mind.
Good altitude.
Any other comments or questions?
I think the only other comment I would make is that over the next couple of months, the committee will be working closely with the staff.
Absolutely. That's that is the mission of the finance committee, is to help formulate the budget for 27. That's exactly right. Thank you. All right.
Chairman Fletcher, about the consent agenda items.
Yes.
I don't think we actually voted on that one. Or did we jump over it?
It's true. We kind of flew right through it.
But I also,
Okay, good point.
and since we haven't, I also just wanted to touch base, since we are a public health department district, and it's flu season, I guess, apparently officially. So I just wanted to know, being this is the first flu season I've been through on the board here, are there any, when that gets declared, plus the epidemiology, are there any different procedures or practices, or how does that, if you could maybe give us a quick update as far as what epidemiology does different or not, and how they do their guidances? Because you mentioned it says there's different guidances.
Yeah, and Becca's probably our epidemiologist, the best one to answer your question in
Sure.
detail, but I believe that their roles remain largely the same as far as monitoring the information that comes to them as far as active cases of flu vaccine. Periodically, and we've talked about this with Dr. Pennock, we might push out a HAN notice to doctors to help them be on the lookout for certain things that may be seen regionally, but otherwise not a significant change in operations, just sort of a change in what diseases are active in our community.
Okay. And do you know, as far as the back and forth, what Rebecca does as far as that, is that something that she looks at and she just gets out, or does it come through you, or is there like a process, a procedure that is current for?
If I guess questions can come in two forms. One, if individual physicians contact with questions, you may just answer those questions in straightforward data type information. If we're actually going to push out information, then that's a review process that includes myself, our PIO, epidemiology, and certainly now that we have a medical director, the medical director would be actively involved in that. In any process where we push out information to the community.
This topic is actually going to come up.
Oh, great. Oh.
And it's going to come up forcefully
You mean today?
today.
Okay. Great. So I
I
didn't
like
see
the way
it,
you're
so,
thinking.
yeah, thank you. Okay, I will be there for that discussion.
Okay. Um,
Yeah, one other thing is, do we know, as Rebecca mentioned, how is this year trending? Since we were talking about trend lines, I love them. For as far as RSV or flu or COVID compared to the last few years.
I
I don't
haven't
know yet.
Well,
Okay.
I haven't looked at that. I do know that there's a spike in this year, but as far as specific trends, I could get that information to you.
Yeah, that'd be great. Thank you.
Well, as Joel pointed out, I guess we do need a vote on the consent agenda. So do I hear a motion to adopt?
Make a motion to adopt the consent agenda.
Is there a second? Okay, are there any objections? Hearing none, let the minutes reflect that the consent agenda was adopted unanimously.
Could I ask?
Medical director report.
Could I ask for a quick question?
Sure.
From Jason? It mentioned that we're working with Bonner for the Sagal Aquifer, and just, I don't know if it would be okay to have him give like 1 or 2 minutes explaining that, being that aquifer is a big deal, and so what's the process? And what are we hoping, what are we hoping to get out of that?
Sure. Yeah, thank you. So, yeah, as mentioned in the Board of Health reports, we are partnering with Bonner County Planning and Zoning, several hydrogeologists throughout Idaho, and also some other private partners to essentially develop a very granular and accurate model of the Sagal Aquifer. So the Sagal Aquifer is in southern Bonner County. It's a very important aquifer for the county. There's several large public water systems and many individual wells in that area, and a very small portion of that area is served by municipal sewer systems. And so throughout Idaho, as we mentioned before in previous meetings, there's a number of aquifers, small aquifers that have been contaminated from nitrates and other factors, both from agriculture or other just human uses. So without having statewide guidance dictating things like septic density, parcel density, what this approach is intended to do, it's really gaining momentum across the state, is to develop very specific to that watershed models that accurately input soil conditions, wells, existing septic systems, so that and actually model the impacts of those for future development, so that planning and zoning commissions, county commissioners can then have more information to make decisions. Because what's happened otherwise throughout the state, if the commissioners, if they don't have that information and then don't have any real understanding of what the impacts would be, and then after wait till after the fact when when there is groundwater contamination issues, it's really a proactive approach. And the way this is being structured is at essentially no cost to the county. So the two hydrogeologists, one of the two is retired, he's donating his time. DEQ is able to they're gain approval at the state level to divert some funding that had already been allocated towards this, and all of that to use this as a model that can then be used across the state. So we're currently working with Health District 7 and Jefferson County on a very similar project. They're coming right on the heels of this, and we're working together to really dial in our approach. And the goal is to have it be data-driven, site-specific, not some kind of theoretical model.
Yeah.
Very specific, and get all of this out of the way, so that down the road, county commissioners, planning and zoning commissions can use that to better, make better decisions in those areas. So that's really in a nutshell.
That's exciting. Yeah. Do we know, is there any possible connection with the Rathdrum aquifer as far as like a spillover or not, or we not sure?
It gets really complicated. There's likely
Yeah.
some connection to it, but just in general, because of the number of users, almost 100% of the users in that area use groundwater, and the water is extremely clean as a starting point. So that's a really good starting point, and that's entirely the goal. So it's really just to assist the county decision makers, because in Idaho we don't have statewide guidance, and in this context, it's really not appropriate, because every aquifer is different. So.
Cool, thank you.
Okay. Dr. Pennock.
Thank you, Dr. Fletcher and board. I'm very excited to give this presentation today. And I want to thank the board, first of all. It's a privilege to be part of these discussions on the clinical services and recommendations for future directions. So thank you for that opportunity. I think this is a complicated and important discussion, but it's in essence a philosophical discussion about where what direction public health should go. And I think that reasonable and intelligent people may disagree on those questions, but I'm confident that this group of reasonable and intelligent people will come to a consensus and give us some guidance going forward of what we should do in clinical services. And my slide's not working.
Let's go to the next slide.
Let me take the keyboard in case we have to put that. Yeah. All right. That's not a There you go. So at the last presentation, we talked about epidemiology and the preventable diseases in the health district, and we spent the majority of the time talking about what we're actually doing in clinical services. This discussion is going to be a lot less quantitative. There's not going to be numbers and graphs, but rather more a qualitative discussion about the direction that clinical services should go. So I'm briefly going to talk about public demand, what the wants and needs of the people are, and spend the majority of time then talking about how to restructure clinical services. So let me start by saying that these ideas are an amalgamation of a bunch of different people. I've spent a lot of hours interviewing people, talking with staff at Panhandle Health, talking with some board members and people in the community. And so these ideas aren't just mine, but rather an amalgamation of many different people. So, and some of you may not know, but Kootenai Health just came out with a community health assessment, similar to what Panhandle Health did in 2003, 2004. Theirs came out at the end of December. I'd encourage you all to read that. It's very comprehensive, lots of data, lots of graphs and numbers, and it paints a very good picture of northern Idaho and what the answering this question, what are the wants and needs of the people. But basically, in my mind, you can boil it down to basically 6 categories, and they're access to care, alcohol and substance abuse, chronic disease, mental health and suicide, problems of aging, and social determinants of health. There may be others, but generally these are the categories. Notably absent is infectious disease. Nobody said we need to have more infectious disease monitoring. So I think, from my standpoint, public health should take a victory lap and say we haven't eradicated infectious disease, but we've made a huge dent compared with the 1800s and 1900s, and we should move on and develop another model. So what I'll present is 8 different models, categories of focus, if you will, that the board can look at those different highways and they can pick and choose the best ideas of each. There's quite a bit of overlap among those different categories, but you can choose a category, a highway, or you can choose a la carte from the best ideas of the bunch and put together your own program. So what I'll present is the smorgasbord of ideas from which you can pick from. At the end, I'll give my personal recommendations about what I would do, and then I have a few requests of the board at the end. So let me address the elephant in the room first. I would like, by the end of the meeting, the board to address the following question. Should we continue point of service care in bricks and mortar clinics, or should we shut down the clinics? And the reason why this is important is because clinical services is at an inflection point. We either have to aggressively staff the clinic and recruit and replace people that are no longer with the clinical services, or we should cut bait, so to speak. So as you're listening to the presentation, think about that question. And in that light, these are the 8 different models. Some of them are more clinic heavy than others. You can imagine some in which there would not be a clinic present at all, and obviously some where there would have to be a clinic present. So they are informed care, and I'll tell you what that is in a second, epidemiology focused, AI focused, education focused, unique clinical model focused, public coordination, public advocacy, opioid settlement funds, and a couple of miscellaneous things that didn't really fit elsewhere. So let's go through these. The first one, in my mind, was a replacement, if you will, for Care Plus, which is the primary care that we have now at the health district. And this would be a mission statement for that model. Informed care is actually an acronym. So I is informed consent, and no mandates, F, freedom of for individual decision, options explained, risks and benefits discussed, medical freedom, education, drug-free treatment as a goal, cost-effective care, alternative treatments available, rights of patients and parents, and more education. So what does that really look like? Panhandle Health would serve gaps in community care. They'd be an alternative alternative to urgent care and emergency room visits. So this would cost the presumptive cost savings of such a model. Access is a huge problem in northern Idaho. So just to give you an example, I had a meeting with Kootenai Health, and they said their wait for women's health or a gynecological appointment for a new patient is now 3 to 4 months. So we would focus on access, timeliness issues, that is patients that couldn't get in to see their primary care physician for several months. Could be patients who are new to the medical system, and it would supplement, not replace, the current patient panel. And we would supplement it, hopefully with somebody with an interest in chronic disease that could supplement the women's health and gynecology that we're currently doing. We would modify the scheduling to include online scheduling. We have phone and text scheduling currently. In my world, we would fully utilize the medical reserve corps. For those of you who don't know what the medical reserve corps is, this is a nationwide government-run voluntary system of mostly medical professionals or related professionals. And I would envision a lineup of these part-time workers that many of whom are retired, many of whom still have Idaho licenses. They're workers who don't want to work full-time or even part-time, but maybe would want to put in 4 hours a week or 4 hours every other week. But I think they could be a tremendous resource. There's obviously liability questions that need to be answered. I should say there's going to be ideas in this presentation that people love. There's going to be ideas that are mediocre, and there's going to be ideas that people hate. So just make notes of all these things. I think free clinics is a possibility with the MRC volunteers. Public health goals would be clinical coverage for all 5 counties that we would tailor to the specific needs of each county. And we would incorporate chronic disease, nutrition, alternative treatments, and prevention programs into each of the counties. The financial goal is pretty lofty, but I think can be achieved, and that's revenue neutrality. I don't know if you want to discuss each of these or wait till the end of the presentation, whatever your preference, Dr. Chairman. Keep going? I'll keep going.
I think what Dr. Pennock has said is if you have a question, you're welcome to,
Please, that was my intention.
including our guests.
Yeah. Commissioner Corn.
So you made a comment that in Kootenai County, the gynecological appointments are 3 to 4 months out with the Kootenai health infrastructure.
Correct.
Do you have any idea why that is? Something that our sector needs to do a better job at?
Well, I think it's the lack of practitioners that we have in the area. That's the easiest answer. The same problems that we're having, other private sector institutions are having the same problem.
Sure. One of the things I was thinking is, I think there's a mixture of that private sector issue, how they approach that. I think that in the absence of it, I think you have to be careful of the other people, right? What private sector do. I know there's community development that are focused
No, I think that's right. And there's a couple of areas that Cooney Health, for example, was interested in working with, and we can talk about that at future meetings or whatever. But I think they're very interested in working together in a couple of different areas that I think would be beneficial for the health district and for Cooney, quite frankly.
If I may make a comment, I think, Dr. Bank, you're really touching on the core of the issue here that, when we look at what the epidemiologist report states, if you look down there, they're essentially all infectious diseases is how the epidemiologist is focused. And yet, as you mentioned on those concerns of the community, infectious disease is not the major concern, and the access to care. And there's a whole subset of people who don't have insurance, but they don't perceive that Panhandle Health is something that can meet any need other than infectious disease or travel, vaccines, et cetera. And I think that there's a huge potential to meet the needs of the community and fill that gap for those people who don't have insurance or don't have access right now to medical care. That waiting list would be longer. That's a waiting list of people who have insurance or who have Medicaid, but there's a whole group of people who don't have that, who need help, and they're not getting care, and they don't know that they can come here. And I think where you're going down this envisioning how it should be structured and dealing with this informed care model, I think is beautiful. If once the people of the community understand that, and there are people who are willing to volunteer, and it's not going to be a huge cost issue. We could meet tremendous needs here, and that's what Panhandle Health, I think.
Yeah. Well, it's interesting in Bonner County, Commissioner Korn, that there's been a lot in the media about women's health and OBGYN. It's interesting that those are the two subsets that Panhandle Health, actually the niche that they participate in right now are those two patient groups. Not that we want to do OB necessarily in public health, but gynecology and women's health are a big part of what they do downstairs right now.
Can I ask a few questions? I want to understand the funding better, because I just know historically when I worked for Panhandle and clients would come in, and this is, in the old days before we had the Care Plus knowledge. And I lost a certain percentage of clients because our sliding fee was not at all competitive with what the federally qualified health clinics do. But the issue is, we're already talking about the fact that the county has to support clinical services, and I'm just trying to figure out, how does it work financially if we're going to be absorbing the population that, may not have funding?
Yeah, no, I think it's a great question, and one that, again, this is one of 8, so we'll get through the other potential models. But how I would answer your question now is that, first of all, the clinic right now serves less than 10% of patients on a sliding scale, which is interesting. So they serve a pretty broad variety of payers and patient demographics. If we were to get an influx of indigent patients, then obviously that puts strains on the county. Now, what I alluded to in my previous presentation is there's a lot of room for cost savings that I think we can take advantage of. And so Christine, Eric, myself would work on looking at areas where we could cut costs and increase revenues to make this as revenue neutral as possible. But I hear what you're saying.
Stay up to what we were talking about. The
Federally qualified healthcare facilities have, as we've talked about, have different grants and things that they qualify for. A lot of which I think are kind of uncertain right now as far as how far, and so they are only going to provide those services as long as, say, there's the current Medicaid expansion, as well as the same grants. But if the grants dry up, they have no mandate to continue if there's not grants, and they can't go ask the county for money or that sort of thing. So it's a different system for what they're providing, and though there might be they might think that they're not necessarily doing a deeper, primarily chronic health remediation, I'd say, to go in and figure out, okay, where are the main chronic health issues and how do we reduce the disease burden and morbidity of those illnesses beyond just the current model of drug prescribing for that stuff. So though there are some programs in diabetes and all that kind of stuff, the idea is that it's a different focus. And if the money dries up for them, then they no longer are going to be probably providing having the same competitive nature that you were talking about, because there was large amounts of money going with those facilities. And so if that dries up, they no longer have that extra to drop the sliding scale. More need here. All the communities will have more need.
The only other question I have about the model is the medical reserve board, because I know I've done nursing volunteers, and I have not been able to get clinical hours because of some, there's a rule about being able to provide clinical services. So that would all have to be sorted out. I don't know if that's like a legislative thing or how that all works, or it's something that's.
I think there's a lot of questions that would have to be ironed out, particularly legal questions and liability questions, but maybe stay tuned for February's board meeting.
Yeah, if I may comment on that as well, it's really interesting. As I have spoke with the MRC people, and there was a list that they had of people who, it was huge, and a lot of people fell off the list because nobody ever contacted them. And so maybe that contact was because we weren't utilizing the resources available, and so there was a disintegration of people who'd moved or died, et cetera. But just recently, they reestablished that list, and so these are active people now. That if we were able to take advantage of that at a reduced rate, which we've never done, that's going to reduce costs right there, because some of those people are going to be willing to do it voluntarily.
Exactly.
No, but I mean in large. I mean, the people themselves were saying that they didn't even know who was on the list, and there was something at one point like 1,000 people on the list, and
We
they
happen
only
to have
contacted a few.
the manager in the room. Jennifer, you want to comment?
So, speak to that.
Uh-huh.
When I came in March of 2023, the list had almost 1,200 volunteers on it. And we went through and made phone calls and sent emails to every one of them, and it got scaled back. We're pivoting between about 400 and 410 volunteers. That's with people adding and removing themselves. And I think I submitted that list to Dr. Penoff. I think we had at least 150 of those were either licensed healthcare workers or folks with healthcare experience. I don't know if we narrowed down the exact number.
I didn't, but I would rely on you to do that. And I remember you saying that there's that number of licensed clinicians. So I think it's worth exploration. I don't think we have to discuss it right now, but that's what I would.
Well, just a second quick point I was going to make, though, is that if you do have someone employed, even at a reduced rate or whatever, and they see one patient an hour, it's the same overhead if they were to see 6 in an hour. So, I mean, in other words, if we transition to the point where people really see this as a destination, that will then again pay for itself, even if they're paying $20 on a sliding scale. It's $120 coming in rather than 20. And so that's where I think if we're thinking outside the box more of entrepreneurially and setting the tone that, no, we want to fill that gap. We're not just an infectious infectious disease entity, but we want to fill that gap of healthcare needs that are lacking, then this would be an institution that will really have a profound impact on the health of North Idaho.
Oh, yeah.
I don't know what the scope of the specialization is really at this point, but it just seems like such an untapped reserve
Yeah.
at this point.
Chairman, if I may just touch on that, this is strictly a liability issue because our volunteers are not covered the same way as our employees. So if they make a mistake, then we're subject to the Idaho tort claim, which means the district would be liable up to $500,000 per incident. So we've hesitated to use medical practitioners in a medical setting because our insurance does not cover their activities the same way it covers our employees.
But I would think that that's where the legislature, could maybe step in and make this an issue, because if they care about healthcare but aren't going to cover practitioners, you're not going to get healthcare. So
And I think that speaks to Dr. Pennock's mention of free clinics, because there is an exemption of liability for medical practitioners in a free clinic setting, but that has specific criteria that have to be met. So there are options there. So.
Okay. Quick on to your point, is that where we could be an institution where there's actually a different perception of it. And one of the ideas is, if we're wanting to really address chronic illness, then we could provide the appropriate training for those providers on newer functional medicine type protocols that actually address the underlying chronic illnesses, in addition to the regular standard of care type management in that process. And that can be very exciting because a lot of people are aware of that and want to learn how to practice in some of those newer ways while they're still applying their traditional, good quality of care. And that would be very attractive, even in lieu of pay potentially, is to be a center that trains people on how to approach that.
Yeah, and that'll be part of another model
Okay,
that we'll talk about. Let me just go on to the next model, which is not forwarding. but that's bizarre. Maybe it does need batteries. All right, next one is epidemiology and emergency preparedness model. When you think about the things that public health should be doing that the private sector is not doing, these are a couple of things that come to the top. So in this model, Panhandle Health would continue to monitor infectious diseases for epidemics and pandemics, but it would also increase its role in emergency preparedness. For example, monitoring bioweapons, chemicals, EMP, radiation threats, and it would be an increased clinical role as the command and coordination center for regional healthcare responses to health threats. Next slide. We would expand epidemiology to include the monitoring of chronic disease and identifying chronic disease epidemics. Examples listed there. We could also potentially participate or create internal research of health problems not studied by commercially funded projects. Examples might include vaccinated and unvaccinated populations, outcomes research, or local disease prevalences. The public health goal in this model would be greater real-time surveillance for a wider variety of health problems. Comment. Let's go on to the next one. Next one is fairly similar, but it's artificial intelligence in public health. And so Panhandle would develop disease-specific AI algorithms to monitor things like mortality, infectious disease, chronic disease, bioweapon threats, outcomes data. And I'll speak more about outcomes data in a second. One out-of-the-box thought is to develop a regional AI algorithm for access to care. So this would be a patient would go to a website or app, be able to match an appointment with geographic availability in the region. This would take buy-in from other institutions and scheduling data that they would provide. There would have to be some kind of verification on the patient side that they actually made the appointment as promised. But I was trying to think how institutions could game this, and they will, but if they overpromised availability, then they would have to accept those patients, which really de facto solves the access problem in and of itself, or risk let's say, a decreased grade on their social media score or whatever via that website. I think there's probably, from what I've read, from I think what Eric's read, rural health money that could be available for something like this, or grant money available. So the public health goal for this model would be more real-time interactive data, better access to epidemiology and outcomes data. Comments, questions? Next slide.
Greg,
Yeah.
as far as the first part there with like the the different algorithms and the chronic disease stuff,
Sure.
And even the bioweapons threats, is that something that we do on some level now, or is it more through like connecting to other partner agencies, especially because we're the for the whole North Idaho, we're the biggest populated region here. So.
Yeah, that's a good question. So the most real-time data we have is, as you'd imagine, with infectious disease. We really don't have much in the way of real-time data with anything else. Okay. So even infectious disease mortality is tough to come by. A lot of the reason is because that goes through the state, through health and welfare, and it's just, there's a time delay, there's a lag. So the data that we look at now are from 2023, 2024 is just starting to come out, and that doesn't necessarily help us on any real-time basis. So it would put, in this model, it would put more control regionally into some of those questions.
Okay. Question on corner type stuff is, basically stuff that happens at the hospitals versus in the county. The hospitals, is there any requirements that they have to coordinate that data with the county coroner's office at all, or is it kind of a different silo?
The hospital has
morbidity and mortality data at like hospitals versus in the county. Is there any coordination on a regular basis of that data, or syncing up?
Not really. I mean, because in other words, we only handle cases that are considered our cases. So in other words, where our relationship is with the hospital is if someone died within 24 hours of being at the hospital, then that becomes our case.
Okay.
Or someone who was in a motor vehicle accident and they were in the hospital for a long time and they died after 3 months, but it was because of the motor vehicle accident or a potential homicide, et cetera, then that becomes our case. But other than that, we don't share data per se because we don't need to know everything that goes on in the hospital.
Yeah. So then the infectious disease and other stuff, a large portion of that data is in the institutions, not in the county, because the county's usually not as much of that, I would think.
Right. Our role is unattended deaths.
Yeah.
But my impression too is it's institutions to state to local. So there's this intermediary that maybe we can do a better job of grabbing that data real time.
Have to work through that.
Yeah. The next model is the education focus model. And actually this is working now for whatever reason. In this model, we would, Panhandle would serve both in public and professional education. We would serve as a public health education hub for Northern Idaho, focusing on disease prevention, promotion of health, prevention, early treatment of communicable and non-communicable diseases, chronic disease, education, prevention, and treatment. You can imagine many educational programs, nutrition maybe being at the top, healthy foods, organics diet, education, food chemical avoidance, dangers of ultra-processed food, sugars, seed oils, natural treatments, alternative medicine, environmental, chemical, EMF exposures, including those listed. Some have recommended a home economics type of education for young families that would supplement what they're receiving or not receiving in public education. We could sponsor community forums and or community lectures. And so this public health goal would be education of the masses as a means of promoting and influencing health. Questions?
You know, if I may add a comment to that, I was on the board of a school that we wanted to make sure that our students were being prepared for college, and so I got the curriculums of not only the colleges so that we could help gear them towards what they would need, but also the curriculums for health from the high schools, et cetera, in the area. And the science classrooms for non-science majors I found to be stunning, and I think it would be contributory to this discussion. What I found was that a substantial amount of the science that was taught in relation to someone who was not interested, but they had to take some required science, was devoted to evolution, but it had nothing to do with hardly at all nutrition or the appropriate exercise and the integration of all of these things that are so critical to health. So even our educational system, from what I can see from their curriculum, has really dropped the ball on this. The home education, the home ec type education, the cooking education, all of that stuff has largely been deleted from our society. That what we assume in our age group everyone knows is not true.
Right. I just want to confirm, I think that's a critical nature because it addresses some of also like the determinants of health, even just having the basic knowledge that's needed to achieve some level of vitality in your life. And it's now absent.
Yeah, absolutely. And it was stunning to me. I just assumed there was some. There was like almost none.
Yeah.
At least in that time period I looked at it. Now, maybe it's changed in the last few years, but probably not.
I should also say there's a professional component to this. We could be a training site, assuming the clinic persists, for rotations of clinical personnel, really of all levels. I should say we've already had a meeting with Kootenai Health Family Practice regarding reinstituting the residency training program here at Panhandle, and they are very interested in that. We worked with NIC to get medical assistants. We have a relationship with them now, but you could imagine really all levels. Panhandle could sponsor regional conferences or lectures, and certainly the training program would be important for our staffing issues. If there was a clinical person that came through, saw public health, decided they liked that, like the people that worked here, that'd be a huge recruiting tool as well.
Comment on this one.
Yeah.
Going back to your first model, which would be your reimagined point of service,
Yes.
and recruiting this body of retired people, reserve, Army Reserve.
Yeah.
One of the issues, in addition to liability is going to be the outstanding issue here, but another one's going to be CME, continuing medical education. So if you were to develop programs where you have homegrown CME,
Good
it
point.
would be act synergistically with,
Yeah.
with say, your
Sure.
core of external providers.
Good idea. Perfect. Next model is the unique clinical programs model. This is more of a point of service type of model, that there would be clinic involvement rather than simply educational, although education would play a huge role. You can imagine many alternative prevention and treatment programs. The Weston A. Price model with food as medicine, where we could manage different chronic problems through food as medicine. One unique aspect of this thinking out of the box again could be patient-specific advice and advocacy. This would almost be like a mentoring program where, again, MRC person or clinical staff would take a patient under their wing that's having difficulty navigating the healthcare system and at least guide them through the system, somebody that's familiar with healthcare. Could also be disease-specific advice, depending on the qualifications of the MRC clinical person or the clinical staff. And the public goal for this model then would be providing a clinical niche that's not supported in the private sector. Question. And there are many more programs that I'm sure you could think of that could be unique to the area that aren't provided by
Just
private health currently.
this is more of some of what we kind of are already doing, but in a kind of revamping it and retooling it so that it's serving lots and lots of people. I mean, it's kind of what got the whole health coach industry going, is because people need help
Right.
with coaching.
Yeah.
And if we applied an appropriate, mindset model to that, then it would be a very inexpensive way to reach a lot of people, that then you could bring in medical support as needed, but you'd have your kind of paramedical support through this and then bring it in through it. And one thing that could be very fun would be, as from a research point of view, where we actually do research on the different approaches and get effectiveness and outcome information so that we can then publish that.
Yeah.
And become a center for actually verification, validation, and support the things that really work well. Quite fun.
The next model is a public coordination model. So this would, in this setting, Panhandle would have less focus on direct point of service clinic services and more focus on coordinating those services. This model was actually, the people that came up with this were the front desk people in the clinic, since they're kind of the de facto experts in this area. People call and this is what they do. They know the resources in the area, and so they send them to the appropriate place. This would just formalize that a little bit more. We could have a reception area in this building staffed with a full-time resource line. We could coordinate with county-specific resource managers, either individuals or nonprofits in different counties. Examples would include healthcare services per se, but also coordinating services with food banks, opioid addiction, domestic violence, suicide prevention, senior care, mental health. A social worker might be a logical choice, or perhaps an employee that's already here familiar with area resources. And the public health goal in this model would be a 9-to-5 service as an alternative, or in conjunction with 911 services. You can imagine how this might reduce the 911 burden in the area. Question?
The 911 service alternative, you mean for?
Well, I don't know. I mean, I'm not an expert in 911. I would guess that a good percentage of 911 phone calls probably have nothing to do with the true emergency situation, but rather could be answered in this context. Peggy?
So with this, the last model that we were talking about, the public coordination.
Uh-huh.
So one thing that I have seen historically is Panhandle has always had a large health promotion staff. They're mainly centered in Haiti, and along with that key front desk person, I think that we could look at key people in each county. Because when you live in a county, you you know that county, you understand that county, and people know you. And that to me is like looking at how do we serve each, because every single county is going to be different. We all have different needs.
I agree with you.
And everything else.
In that second bullet point, I had you in mind when I wrote that. County-specific resource managers, that would be those key contact people. So I agree with that in this model. The seventh is the public advocacy model. So this would be a non-clinic type of model where Panhandle would be the coordinating agency for regional health advocacy. Medical freedom, we would set the standard for informed consent. We would establish a consolidated Idaho Patient Bill of Rights, which to my reading doesn't really exist at this point. We would ensure that there are no mandates. We would act in the spirit of Dr. Fletcher for managing the commons, safe air, water, soil, and food, in conjunction with environmental services, who already does the restaurant inspections. This might include more specific food testing or more specific air, water, soil testing, again, in conjunction with environmental services or accredited labs in the area. And so we would enforce health policy and statutes through public pressure, for example, access to care, safe medical practices, and we would be the driver for local, county, and state health system changes. Questions?
One of the things is, so like say with things like the rabies and some of these other stuff, I believe that we send those out somewhere. So one option is that where I think that the coroner's office is developing a center, it could be a regional center, that we consider developing what would it take to stand up a certain lab where we actually become, we're now a client, we basically provide services to even other districts, like regions, to then fund it so that it's at least neutral, but it builds out resources, so if the only resources in Boise, that kind of gives us very fairly brittle chain. So when we're looking at these different aspects, even some of our soil water sampling can be done here, in the large soil is not very well built in certain areas.
Yeah,
So,
no. I guess I would say, rather than getting in the lab business, that we partner with a lab that's already doing that and accredited, and probably Jason could give us a lot of information if that's the direction we decide to go. He and I have talked, and I think there's a lot of commonality with clinical type questions and what's already being done in environmental services. So.
yeah, I was thinking that it'd be best if that left to be local, like.
Oh, I agree.
Like in the county or in, for sure in the district.
Jason, what are the labs in the area that we could utilize?
There are several. There's several private labs. There actually used to be a regional public health lab, Idaho Bureau of Labs in Coeur d'Alene, right next to Cooting Health, that serve many of those functions, and that's really why most of the sent to Boise now. And really, depending on the lab, there's Accurate Labs nearby in Hayden. Silver Valley Labs has always been an excellent resource for us. That's transitioning, so it really depends on the nature of testing. I know this is touching on some medical, some environmental type testing, but just in terms of lab accreditation, everything that it takes to maintain that, I would agree that unless we had a lot of support regionally, it's an extensive undertaking to maintain, especially for rabies testing and those types of activities.
Yeah, be something that we could look at contracting, where we don't have to run ourselves, but we can contract. Then if the lab knows that they can expect a certain amount of business, then they can then stand up the equipment needed to do that type of thing. So
We might also point out that earlier you talked about the epidemiology model and monitoring more chronic diseases. And now you have this public mode model. And you can imagine if you were to harvest a great deal of environmental data, more nuanced and specific to our region. Now, map that data with now your stockpile of epidemiologically tracked data and see if you can mine some important trends.
Yeah, and I think there's definitely overlap and some of these models that fit together nicely, some more so than others, certainly. The last one is opioid settlement funds model. This would be continued future expansion into drug treatment and recovery program within the constraints of the settlement regulations. In this model, it has to address opioid addiction, of course, but there's also a lot of overlap both with mental health and potentially other services, clinical services that we could take advantage of either personnel or expertise in the settlement funds. Typically, it involves medications for opioid use. Kate Hoyer has already done a lot of work in this area, and she's an expert. So we haven't heard from her at one of the board meetings, so hopefully she'll give us a presentation at some point. But this would create a one-stop shop for clients seeking treatment and recovery, reducing barriers of starting and staying in treatment and recovery. In-house drug testing could be a part of this. This is certainly not my area of expertise. In my world, psychiatric nurse practitioner, physician hire might be a good person to run a program like this, at least for the treatment part of it, not necessarily in prevention and recovery. Question or comments from Kate?
I think whatever model it's part of, I think there's a lot that needs to happen there. And because just working with patients over the last almost 2 decades, usually each treatment type facility has its own part, and none of them I've ever seen put the whole thing together. And so there's the get them off the chemical dependency, but then there's not the recidivism, the getting back into it, the lifestyle, the addressing the root causes, the basic knowledge that maybe your grandma should have taught you, working with trauma recovery, all of that kind of stuff, and then working on the nutrition aspect to armor your brain to not go back there, and all of those aspects. I think we could help develop a model that then could be exported, nationwide, and doing that. So it'd be very fun.
And if I may, Chairman, Kate's team is building a presentation that will be at a forthcoming meeting. We were hesitating on that coming forward at the February meeting simply because of our discussion of risk management, but it could be at that meeting or likely the March meeting.
A couple of miscellaneous components that didn't really fit anywhere else, but transportation being one. If transportation is truly one of the social determinants of health, then maybe just purchasing a bus or van to provide transportation to and from outlying clinics might be a reasonable option. The other idea is a full-time grant writer, the goal being to increase private, state, federal funding. The more I hear about grants, the less enthused I get, quite honestly, except that they're obviously good sources of money. I think they need to promote the goals, values, and values of the board here. I think they need to be simple to administer. They can't take up a lot of administrative time. And they have to have few restrictions and strings attached. Any comments about those two things? So let me give you my recommendations, and then I'll pass it back to Dr. Fletcher. And I'm certainly, and let me just back up and say, in an ideal world, we would have components or all of these things under public health. There's a lot of good ideas in there. Unfortunately, we're constrained by financial budgets, and so we have to pick and choose. So that's the hard part. And that's where it gets a little bit dicey. But here's my version of it for what it's worth. I would keep the clinics operational. And my rationale are threefold. One is it's easier to change the clinics and adapt to changes in funding and gaps in healthcare than it is to reopen the clinics once they've been dismantled. It keeps our clinical options open. We are in a time where we're not sure how this rural health money is going to come down. We're not sure what that means, where funding is going to be. So we may want the option of a clinic 18 months from now. I would also say that clinical services has one of the few mechanisms for actually generating revenue. Not to say that we're running the clinics on a net revenue positive basis. We have a ways to go, but at least we can generate revenue. I would develop that informed care practice model. I would advocate for 5 functional clinics tailored to each specific county need. I think it's really important that we set specific goals and health outcomes measurements. The specific goals and direction is under the purview of this group, defined by the board. The health outcomes measures should be set by this board and by the county commissioners. How do we know what we're shooting for if we don't have a goal? Give us a goal, give us a direction, and let's measure it. So you can imagine some health outcome measures. These are 3 that I've thought of. There's many more, but access to care, hospitalization, and emergency room visit rates, which would be a surrogate of cost savings, I think, if we saw those rates decline. Life expectancy, premature death rates, I think are important for general purposes. We need to solve the staffing problems that I outlined in the last presentation. We need to restructure the current salaries to bring them in line with the regional salaries. We need to, in conjunction with Sandy, explore aggressive marketing strategies for recruiting. In my mind, recruiting is in the professional realm, though. It should be physicians, nurse practitioners that are recruiting other physicians and nurse practitioners. That shouldn't fall to HR alone. We need to develop a strategy for staff retention. I think we need to work on being less siloed, work with other departments, better utilize RNs, dietitians, and as I've said, utilize the MRC clinicians in some way. I said in the last presentation I'd expand physician leadership in the clinical services. In my mind, that means a full-time doctor that's seeing patients down there and that could perhaps eventually become the medical director. That full-time seeing patients is not me, for the record. I would expand epidemiology and develop and incorporate chronic disease surveillance, outcomes data, as we talked about. And whether we're in the vaccination business or not, I think we should look at vaccinated, unvaccinated morbidity and mortality, vaccination rates, and adverse event rates. I think that's good public health policy. We should develop an informed consent policy and forms for vaccinations. And maybe most importantly, number 9, and we're starting to do this now. We have a lot more work, but in conjunction with Christine and her staff, and also with Eric, obviously, to take a deep dive into each of these clinical service programs and decide where we can cut costs and where we can increase revenue. So if a program is revenue negative and it's duplicated elsewhere in the private sector, then we should consider terminating that program. Again, overall, break even or net revenue positive would be the business goal. I think that's a high bar. I don't know with 100% certainty that it's achievable, but I do think there are a number of areas where we could achieve cost savings and increase revenue. And this, if it's not already clear, I'm very, very cost conscious of this program. So I have some requests. If you choose to go forward with these recommendations, and that's obviously up to the board, I would like the responsibility, but also authority and autonomy to carry these out in conjunction with Eric. Eric and I work well together, and just to make clinical service run smoothly between Christine and Eric and I to put together, carry out the clinical services budget, make all clinical personnel decisions, hiring, termination. I think there should be a medical person, and I think the medical director is the obvious choice for final approval of public media announcements involving medical content, and in conjunction with, again, Christine and Eric, taking that deep dive into insurance contracts, vendor contracts, and really seeing where we can optimize the financial state of clinical services. And I would hold my feet to the fire. Give me 18 months. It's a short timeline, and part of the reason for that, those requests on the previous slide, is not for a power grab, it's to accomplish this deadline. That's a very aggressive deadline, but I would say give me 18 months to hire a full clinical staff and to approach budget neutrality with clinical services. We kind of acted as a trial period for 6 months. My 6 months trial period is up in March, but if you want me to stay on and continue to carry out in any capacity, whatever you decide as the direction to go, I would like a full-time salary for that. My personal goal, however, would be to get the clinical services to a point where it essentially makes me obsolete, where it runs on its own, and either another medical director takes over, or I continue on as medical director, but greatly reduce my hours to part-time or even PRN as needed. Peggy asked me the first time we met, what's my philosophy? And I gave you an answer, but here's my answer again. First, do no harm. A new public health model needs to be established, and it should be consistent with policies and principles for the people of Northern Idaho. So what I would request from the board is that general direction, obviously, of where we're heading. The goals could follow. They don't have to be today, but a general direction. And the reason that, again, it's so important is we have to decide whether to proceed or not with hiring a clinical staff. We're kind of at the fish or cut bait time period. We can't go another month. We need a yay or nay. And then I would ask to modify my role, either in the bylaws or job description, to accommodate those requests. Thank you.
Very good.
Chairman, do you mind if I ask him a question? When you say fish or cut bait, what is the plug the dike position or positions that you feel would need to be in the next 2 or 3 months?
Yeah, I think the first one would be a nurse practitioner, full-time, that could complement the existing nurse practitioners, and it would be more oriented towards taking care of people with chronic disease. That'd be the first request. The second would be a physician. And I think the recruiting timeline of that probably would take us into budget 2027, but it takes a while to get these people. So starting that process sooner rather than later may not have any effect on this year's budget.
So when you say chronic disease focused, you're meaning that their time slots are reserved for people with just the standard like
No, I think-
hypertension,
Yeah, I don't know that
Yeah.
you could
diabetes.
formally advertise for something like that, or you could just make sure, yeah, people are aware, and would just be another practitioner. The current nurse practitioners already see chronic disease. It may not be their interest or expertise, so having somebody that is more familiar with cancer, diabetes, heart disease, obesity, so forth.
And just so I know, because I'm coming from my paradigm and perspective, when you're saying chronic disease treatment, do you mean through the normal AMA model standard of care?
Not
Or do you mean-
necessarily. In fact, no would be the
Yeah.
answer to that.
Right. So that then gets to a highly specialized trained individual, which most nurse practitioners don't do that. So partly it's a whole paradigm shift. So partly we have to figure out if we do that, then you would need to advertise for that because you're actually getting someone. who's-
I'm sorry. We would
Yeah.
advertise for the position. Absolutely.
Yeah.
Yeah.
Because it would-
I thought you meant for the services.
Well, I mean, the services, we would know that because we can set up, there's, larger clinics have like sub-clinics. So we have like this clinic and that clinic that's part of the same facility. So we
Right.
could have the, chronic health that's on our website that said, these are the things, this is the approach.
Yeah, absolutely.
and all of that. And then people will probably get quite excited about that. And potentially, so it also depends on what's wanting to be managed. So naturopathic physicians could fill that role as well.
Sure.
And they can prescribe most things. They don't prescribe in Idaho scheduled drugs, but trying to not work with that. You're on.
Yeah, I think what that looks like is certainly up for debate.
Yeah. But you're saying though is to initiate the fish or cut bait. You would like to try to
Well-
initiate the hiring process at least.
Yeah,
Short
I
order.
need to know whether we can go out and actively recruit, because right now we aren't. And I wouldn't expect that people are going to show up on our doorstep to ask for work. So because of that, we're essentially one nurse practitioner away from disaster, closing the clinics anyway. So it's going to be a de facto closure of the clinic if we don't actively recruit.
Question is the 3-month wait time for women's services.
Yeah.
And that's just talking about like PAPs and screening and just like the normal, I would think, just the normal keep women running well and healthy and all that support. So either we could say, hey, what's needed for that to change in short order from the local like food and health post, or we could say, hey, there's a medical gap because that can sometimes be too long for people to get something seen.
Well, I think, yeah, I mean, we fill that gap, and maybe it's making the public more aware that that's one piece of what we fill.
Because that, I'm saying that would be a less specialized provider, of which there's a much larger pool. So that could be a hire specifically if we know that there's.
Oh, you're talking about hiring specifically an OBGYN, or?
Well, yeah, I mean, they could do other stuff too, but that's someone that, if it's not necessarily trained in the traditional, like the short medicine model, that is great at all the other stuff. It's also important. So I'm saying that there could be a couple, that's why I was trying to figure out, like, what are the exact plugs needed?
Yeah,
to-
well, I think it's a good question, and I think diversifying what we offer is probably the most important thing, because we have that niche right now.
If I may, I think there's a number of people who are functional medicine trained that are also general family practitioners who would handle
Great.
everything anyway. So I don't think that'll be, it doesn't have to be OBGYNs.
No.
Yeah.
Yeah, I see, I hear where you're going, and I think that's exactly right.
Dr. Pinnock, my question is, we've got 5 counties. How do you envision this to be structured if you've got one physician or one practicing nurse? Are they going to be going to each location once a week?
Well, that's what happens now is they go to a different outlying clinic
Right.
every week. And I think that we obviously don't have any redundancy at this point to make those clinics robust. But either we're going to have to travel or we're going to have to bus patients come in here. I think either is on the table, but we have such nice outlying clinics that aren't being used that we should take advantage of in some way. And so I think that us traveling is probably the best short-term solution anyway. But being able to, boost all clinics, I think the commissioners look at the clinics and see that they're not busy, and we need to provide those services to all the outlying counties, definitely.
And that was one of my other questions. Have you been able to consult with the Board of County Commissioners from each county to see what their expectations are?
No, I've been too busy trying to get to know Panhandle Health and do my review, but it's certainly on the agenda. We're talking with the Bonner County Commissioners on Wednesday, hopefully Boundary soon. I think Cooney might be in the works, so yes,
Yeah.
I think we need to talk to all of them.
Yeah.
Absolutely.
Yeah, I like what I'm seeing as far as the options that you provided. It could be a hybrid of those options. There's a lot of decisions that need to be made to give you, inputs on what direction.
I agree, and that's why
Go.
I'm giving it to the people smarter than me.
Well, in light of that, I think perhaps we need to make a motion to put on the agenda for next meeting, perhaps to make, a decision as to what the next steps are for the medical director so that we can keep this ball rolling.
Right. My intention for the next meeting, and we may be able to do that, I wanted to invite, or we will invite, Idaho Risk Management. Because any number of these options are going to have liability consequences. And so I think we need to hear it from our insurance, the insurance company itself, as to, will they cover our back? I mean, can we do this?
Okay.
And so I think finding out, can we do it, would be a step.
Early in the meeting.
And then another step is, can we afford it? So, I mean, I certainly we need to have some urgency to making a decision. I wholeheartedly embrace the spirit of your question, but there are some predicates.
Sure.
And that's the only point that I would.
Sure.
I would sort of say that the underlying assumption of your recommendation, if I may summarize it in this fashion, and it would be, if you build it, they will come. So you want to staff up, you want to scale up, you want to keep the lights open. Now, sometimes if you build it, they do come, but that's not a guarantee. So what measures should we take that would promote, if you will, the goodwill of public health? I mean, the take-home message of the workshop we held in May was that public health has a trust issue. And I read daily that this is a true, this is true. Now, there may be individuals who don't want to believe that, or they downplay it, or think that this is much ado about nothing, or move forward, or whatnot. But the reality is, public health in this country has suffered a setback in trust. So if you build it, do we have sufficient trust in the community to visit our clinics and trust that we're going to provide appropriate care? And in that regards, that immediately begs the question about advertising, public relations, and that whole bailiwick of issues. And I don't know if now is the time when Commissioner Kwan would like to, we talked about this on a conversation a while back, and it doesn't have to be today, but I just want to point this out. If you scale up, just remember your premise is if you build it, they will come.
Mhm.
That's a premise.
Mhm. But if I may make a comment to that, the need is there. You know, so I mean, in other words, it's not, a lot of times when people start businesses, they hypothesize that people are going to come to their place of business, that there's not necessarily a need for that business and they don't do well. But when there is a health need that's fundamental to functioning, it's not uncommon in the coroner's office for us to have subjects who've passed away, and we look into their medical records and they haven't been seen for quite a while. And the need is there. And so if the need is there, and I think from an advertisement point of view, saying public health reimagined, public health reconstructed, brand new, something you've never seen before, I think that would help. And I would be questioning too, except there's such a need. People are looking. They're definitely.
Oh, yeah, there is the
In every health assessment, access is either 1, 2, or 3, and that's why I put it at the top of my list in
Mhm.
that initial slide.
And towards that end, I think Dr. Pennock's earlier slide on the mission statement,
Mhm.
you know, the acronym informed consent, and that plays to your point
Mhm.
of, well, now this is not your fault, you know, your grandfather's public health.
Mhm.
This is a reimagined
Mhm.
model.
Mhm.
And that may go a long ways towards enticing people who, obviously, we're not making the point that there's no need. There's a need.
Mhm.
Our population's sick.
Mhm.
This is manifestly true.
Mhm.
The question is will they seek their care from us?
Mhm.
I really appreciate what you're saying. I totally agree with you. I was thinking that this is not a nuanced thing because partly what we're talking about, and it might make some people fearful and other people excited, is we're talking about addressing the massive elephant in the room of the failure that public health I mean, public health is wildly successful at reducing chronic infectious disease, but the current is not addressing the current health issues in America, aka we're one of the sickest countries in the world now. And so then revisioning that takes a lot of pen to paper discussion, maybe whiteboarding, communication, something that can't really happen at an hour and a half meeting once a month kind of deal. And so part of that would be is we could also use the examples of like what basically what the Department of Health and Human Services is doing with doing roundtables, bringing in different people on that and actually working through it and developing policy. We would have to it will have to be outside of just this. I mean, we have open meeting laws, so we have to do it according to all that, but it would have to be additional stuff in order to actually make it.
Along that line, we had a workshop in May on clinical services, and our commissioners run by that. And I think, like you said, Dr. Fletcher, if you build it, you might come, or you might not come, right? And if we're going to be hiring staff, there's going to be a cost involved. So I definitely think all of the county commissioners need to be on board with, because everyone's got tight hands. So I agree with you.
Yeah, and my understanding is, please correct me, but I think a large portion of what the commissioners are concerned primarily about is it going to be an additional financial burden? One, does it provide useful things to the residents of the county? And then is it an additional financial burden? So if we can come up with a good business plan that makes it a minimal to even less of a financial burden, then that takes that concern away. And the rest of it, does it actually meet the needs that they're finding? So I think those are kind of ways to address for each commissioner. Sorry.
If I may comment to that, I agree philosophically to the more voices, the better, but in another sense, sometimes you can have so many opinions that you create government stagnation. And I think what Dr. Pennick has done is really narrowed it down to some specific steps that if we just presented to the commissioners, and it's good, I would agree, certainly having them on board to realize, because they know nothing of our discussion so far, but if we were able to carve in some time to say, we as a board, this is what we've narrowed down Dr. Pennick's recommendations to, and this is what we suggest, but here's the financial support we need, or at least the emotional support going forward. I think his words and his presentations speak for themselves. I think that this has been incredibly impressive what you've done, Dr. Pennick. I am overwhelmed with the quality, seriously. And I'm excited about what can happen going forward to touching a lot of lives in a positive way.
So it would be, the board does have a medical subcommittee, standing subcommittee.
Yeah, we need to get
Two of
busy.
you are on it.
Yeah.
So it's my, and
Greg.
Greg.
Yeah,
So
Dr. Pennick,
that
yeah.
was, in fact,
Mhm.
we passed this model
Mhm.
3 or 4 board meetings ago, and it was your model.
Mhm.
It's my expectation that that subcommittee now take this presentation and distill it,
Mhm.
Yeah, it needs to be-
significantly distill it.
Okay.
Now, since the whole board has had the baseline information, then the subcommittee will bring to the board now, if you will, more specific, granular recommendations. Now,
Mhm.
that is not written in stone. The
Mhm.
rest of the board still has to pass on it. The
Mhm.
board says no, well, then
Mhm.
go back to the drawing board. But at least it will not be the responsibility of the board to start at ground zero and do the full distillation.
Mhm. I think that's a great idea, because then what we could do is hopefully simplify it enough where we can present something concrete to the commissioners and
Yes.
say, this is our reimagined public health service, and this is how we want to address the needs of the community. We just want your buy-in, because this is going to take some time and some steps, and maybe initially some extra revenues, but we're going to also be really actively trying to find other sources of revenue so that it's not a great burden. But this is where we would like to go, and if we had that, then I think the momentum will carry, and it could be very fast. I think the distillation of what we've already got is more important than creating input. You know what I mean?
And if I may quote Commissioner Matari, when I had a more philosophical conversation with him as to future directions of the board, his comment to me was, and at first I actually took it as somewhat of an insult, but actually it was it was a productive comment. His comment was, look, you're the Board of Health. You bring me a plan,
Mhm.
and I'll either approve it or not, but I'm not going to do your work.
Mhm. Mhm.
And at first I'm going, but I wanted to get your permission. No. Bring me a plan, and I'll tell you whether I'm going to accept it.
Mhm.
But I'm not going to do your work. So we're going to
Absolutely.
do the work.
Yeah, we
Mhm.
will.
And then we're going to bring you guys a plan.
Mhm.
Doesn't mean you're going to accept it.
And in that
No,
process,
no tomatoes, please. No.
yeah.
And then there's fiscal year 27, which the finance subcommittee is going to be working on. And I certainly believe that working with, I guess, in talking with Dr. Pennick, there's one question that needs to be answered today is that does the board want us to move forward with trying to recruit staff? That's going to take weeks and weeks to just work through that process while some of these details are being hashed out, or not. We can work within our existing budget.
That's an excellent question. And I remember, Christine, sorry, I don't remember every line item on that beautiful Excel sheet. But part of that would help would be is what positions currently have money set aside for them would be one. Because if it's actual cash that's set aside for those positions, it makes that decision a different decision than do we have to go ask for money from the county commissioners or not if we're going to hire someone. So if the hire results in an ask, that's a much more detailed than if there's already money for a specific hire.
So let me just put in my 2 cents, and I think that there must be money for nurse practitioner position where we've already put out an announcement for the position through Indeed. I think there's other avenues that ideally I would explore in addition to Indeed. So I presume that there's money for that position, but this is really a practical problem that we have is that should I explore those other avenues? I mean, I call people, get people in from other states. I mean, I'll do whatever I can to get somebody in here, but I've been reluctant to do that until the board gives me a direction.
Do we have the money?
I guess that to answer that question is that there is some room in the existing fiscal year budget for that, and there's some additional funding that we could tap in reserves. So to me, we can move forward in fiscal year 26. We do have the ability to do that. But in looking to fiscal year 27, we'll have to really, in the finance committee, we'll have to take a hard look at the numbers, at the programs. And I believe that part of when we go to the county commissioners to discuss the budget, that would be a good time to explain the whole clinical concept as it's been fleshed out by the board and the medical subcommittee.
Question on that. Would the finance committee be able to present the medical director committee with the available funds for staff so then we would know in the given window of time what do we actually have to work with so we know what to look for if we need to look for it?
The answer is yes to a degree. We're the data that we have is 5 months into the year. So as Christine's explained in the past, there's some ebb and flow in the way, expenditures come. So we can make some rough projections on where we're at in fiscal year 26. Would you like to answer this, Christine?
Yeah, I was,
So currently in fiscal year 26, we're 5 months into it. We are under budget, but as we move further towards the end of the fiscal year, programs are finalizing things. So we will see probably, and most likely based on history, a reduction in the overage. But currently we do have, and I anticipate that we will still have an excess, that our budget was in excess of our current activities and will remain so through the end of fiscal year 26. Now, if we see that, if you choose to want to front some funds to start getting personnel in anticipation of standing up clinic, expanding clinic, then the board can commit a certain amount of dollars to have funding to do that in our investment accounts. If you want to commit a certain amount of dollars, we can do that. And also, if we exceed our current budget, we can amend our budget, increasing it. And that does not go before the budget hearing committee like the annual budget does. That would be presented to the board and the board would approve it.
if I'm correct, isn't it true that a lot of the presentations we've had as far as being under budget are related to the fact that money was allocated for salaries that we're not paying right now because of positions being open? Is that correct?
That's part of it.
Okay.
That's part of it. Yes.
Okay. So we're almost taking advantage of money that we haven't been spending.
Correct.
Got it.
You had a nurse practitioner that resigned earlier in the year. money had been allocated for that FTE. So this would be filling that, that FTE. Is that a fair statement?
That's a fair statement.
May I ask?
I-
Sorry, go for it.
I would not look at it as by the line item. I would look at it as a whole. Create your budget, see what we need, see where we currently are by the time you present that budget to us for the new clinical component. Can we absorb it in what we already have? And if we need to increase the fiscal year 26 budget, then we will present that to the board and you can approve it.
And one thing that I think that could be helpful in that process would be a projection based off of current need, the current flow of the current nurse practitioner, what revenue we could expect to come from that person so that we could then know how much of the budget actually comes from other funds versus the actual self-funded. Does that make sense?
Are you asking me or
Well,
Dr. Pennock?
Well, Dr. Pinnock, and probably I'm sure you'd be talking to me. So,
Well,
yes.
I would like to interject on that.
Yeah.
And that is, in that arena, we would be relying heavily on Dr. Pennock on whether we're going to start negotiating insurance reimbursement rates. When will we be negotiating on supply costs? And based on his review of our historical data, what type of services will we be focusing on first? So it would be his expertise helping us build the revenues.
So, Greg, we can probably start working on that together too.
Yeah, no, I think that's it, and that's exactly right. We need to take that deep financial dive into each of these programs and see where the cuts can be made and where the revenue can be generated. And we're in the process of doing that, but we're at the very beginning of that. But to answer your other question, it would be my expectation that each physician, whether it's a nurse practitioner or physician, would pay for themselves, and hopefully, and then some. And I think we can do multiple things at once. One of my concerns is I'm a private sector guy. I'm used to doing things like this. And I know that's not government, but I just ask if I'm going to put an aggressive schedule on making this happen, that I would like an aggressive help in helping me do that.
What decision do we need to make today, or do we need to make a motion today, or what?
I would ask that we decide whether we should go forward, whether I should go forward with hiring, whether we should go forward with hiring and staffing the clinic.
I think part of it would be good, and this is something we probably should get together in the subcommittee and talk about phases, because it's going to be a multi-phase process.
Yeah, no, I get the phases, but the problem is we, from a practical standpoint, we've got a clinic downstairs that's running, but not very vibrantly.
So I think phase one, we could discuss phases now because we don't have to get a lot of phases, but phase one is the one we're most interested in right now. I think, as they say, one is none, and two is one, and one is none, and we have one right now. So, though seem to be doing great, it's only one. So, I think that we need a hire, whether or not it fits the grand plan of what we want to develop over the next 18 months to multiple years. I think we need to hire just to fulfill the current. Like, what happens if there's vacation time and all of a sudden now the clinic shut in 5 counties? That kind of thing. So I think that there is an immediate need, even just for what we're providing right now, even if it doesn't fit into like the grand plan. If that makes sense.
Sure, I think it does. Well, let me be more specific. Can I hire a nurse practitioner, and can I hire a physician? And can I go out and aggressively pound the pavement, make phone calls to my friends and neighbors in other states and say, hey, look, Northern Idaho is a great place to live. come work here.
Well, I'm going to attempt to answer that.
Yeah.
Not until your committee meets.
Yeah. So I'd say
That's a heavy investment. It's one thing to sort of fill a hole in the nurse practitioner.
yeah.
I mean, I don't know, Sandy could tell me that in fact, there's,
So can I hire a nurse
it
practitioner?
wouldn't take much to sort of say, yes, go ahead and hire a nurse practitioner to fill a hole that we lost earlier in the year. It doesn't require really board action. This was a budgeted item. Now, if you want to hire a physician, I'm going to insist that your subcommittee meets
Yeah.
and comes up with a more specific plan. Because I have to tell you right now,
interview.
there are a lot of unknowns in
Yeah.
that plan.
Yeah.
And before the commissioners cough up another $500,000, we're going to need to have some firm understanding of exactly what you're going to, I mean, look, here's one question. What CPT codes are you going to harvest for this new program? I mean, when you sort of say, well, all these new services or even alternative services, and you're expecting then the insurance industry to pay for it, these have to be billable phenomena.
No, I agree. And a lot of the things that I presented probably aren't billable to insurance. Let me be very
Right.
clear about that. And I
Mhm.
agree with you on that. But there's also a lot of chronic disease out there that is billable, and that can happen tomorrow.
Mhm.
So Greg,
Mhm.
what's good is we're trying to come together what we actually need, and so we're all working on that.
I-
But I think that a potential solution, my understanding from talking with and having some nurse practitioner friends in the community, and as well as other communities, they often work at multiple places. So you might be a big stretch to say, hey, we want you 5 days a week, or whatever the hours would be, versus they're like, yeah, I got a job for 3 days a week. I really love it a lot. I'd love to work for public health for 2 days a week, and I don't want to travel 5 days a week, but I'd be okay traveling 2 days a week. So where they could be a 2 or 3 nurse practitioners, because then you also have much more diversification in your.
Oh, But I think you'd agree that it's unfair to offer a job position to somebody, and then the board decides to shut the clinics down.
Oh,
a
yes.
month
Right.
later.
I mean, I beg to kind of differ here a little bit in the sense that if we have money already allocated for a nurse practitioner and we leave it, because generally philosophically what we're leaning towards and where we're going to go, even though we haven't perfectly defined exactly what are the components of that 8 we're going for, but there's a philosophical a synergy here that I would trust him to make the right decision for the nurse practitioner that's already budgeted for. And
And I agree with that.
yeah, and I think we if he's asking if he needs official approval from the board, I'd like to move that we grant him the opportunity to hire the nurse practitioner
Fair
that
enough.
we already have budgeted.
Yeah, I agree with
Can
you.
can I interrupt you? Sandy has been wanting to talk for a while.
Mr. Chairman, we do currently have a posting out there for a registered nurse practitioner.
Voila. There you go.
It has been active for months and we have not had any response to it. Now, is that because the wage is not high enough? I feel like a lot of the things that we offer, like working during the day, no weekends, no nights, no calls. I mean, that is all listed in there, but I don't know that in this day and age that those things are as important as they would have been even 5 years ago.
How much flexibility do you have on the wage structure?
That becomes the question of how far we can go, because then we can't just like hire somebody in here, because then we have to move our current 2 nurse practitioners up who've been here. So it's not as simple as saying one job
So I
and
think,
we can give them whatever they want.
Well,
It becomes, it's more intricate in the budget with that.
I think
Mhm.
one thing, and Dick, let me know what you think, but I think one thing would be is the medical director committee meets with both of you and we discuss strategy on how to implement this.
Mhm.
And we can present that back here
Sure.
because the need is 100% there, but it's more of how do we go about it so that it actually really works practically and fulfills the final.
And we can look at that advertisement because maybe we can help tweak that, which may
Yeah.
help as well.
Well, and I've tweaked it and I can hire these people. I'm pretty confident.
Oh,
It's just a matter, I don't want to go in at whole hog if that's not the direction the board wants to go.
The other,
So again, I'd like the direction and the opportunity to do that. I think that, I can build a nurse practitioner spot. I've tweaked the listing, but I think that there's other venues that it could be presented.
Well,
I'd like-
it sounds like you already have, some contact, some knowledge of people who have interest, and that it would not be difficult for you to fill.
I don't know about difficult. I think it's going to be difficult, but
Okay.
it's highly competitive out there.
Mhm.
Everybody's trying to get these same positions, but I do think that there are nuances that Sandy mentioned that are very attractive to working in public health. There's no call.
Mhm.
It's 5 days a week, no weekends. I think a lot of practitioners are looking for that work-life balance now, and I think
Mhm.
this kind of job fits somebody, particularly coming out of a hospital where they're getting creamed and taking call and tired and losing their family and whatever. So I think there are a lot of advantages to this job, but I think we have to sell it.
All right,
Okay.
so I'm sensing, to use your word, a synergy.
Mhm.
There's something happening.
Mhm.
Chemistry
Mhm.
would be another word. So why don't we do this? Why doesn't the medical subcommittee meet with Sandy in attendance, and maybe Christine both?
I think both.
Mhm.
In fact, yes, both. Then you
Mhm.
decide whether, in fact, it's a good idea to go ahead and move forward.
Mhm.
Then with their, if you will, input, what kind of a salary structure is it going to take?
Mhm.
And then come up with a number.
Mhm.
And then I suppose, if it's the will of the board, we can call one of the sort of interim board meetings, phone call or a
Mhm.
vote on the internet or something. I don't know. I'm sure there are ways to pull this off. Sensing this urgency, do you want to go that way?
Sure. That sounds
Okay.
great.
All right, then consider the following. Your subcommittee is going to meet next week with the appropriate senior staff
Okay.
and come up with a number. Well, I'm not going to speak for the subcommittee. It might be a little premature to hire a physician at this time. By the time you commit to that, these guys have to play in.
Mhm.
So
I would
it's
agree.
one thing to maybe bump the salary 10%, 20%, and they'll give you grace.
Mhm.
You go hire a physician at $250,000 and then a whole stable of nurse practitioners, and you're looking at now a true budgetary impact,
Mhm.
and you might not want to do that without the permission of the commissioners.
Sure.
That would be my thought on the matter.
Sure.
Is everyone in agreement with that program?
Mhm.
Or any comments? Yes, Pam?
Oh, I just wanted to add one thing. You talk about the kind of reputation and trust of Panhandle.
Yeah.
And that's how, and that's why we don't have
Possible.
it works for possibly. It also works for improving people too. So until you improve the reputation of Panhandle Health, you're gonna have a hard time feeling some of the current practitioners. Because they don't trust it, it's here right now. Unless you get a real look at it as though, I don't like that changes. You might, but you've got to be working on that too.
Well,
Not
that's-
just trying to-
It's a very strong point you're making.
Mhm.
At this juncture, I would make your point a hypothesis. If we increase the salary, we'll see if the hypothesis holds. I mean, money may speak. I don't know. I'm not saying you're wrong, but if you pay enough money, we'll find somebody who will love you. I mean, I don't know. Obviously, what you're saying is true, and I'm really not intending to put it down. I think that is clearly a consideration. On the other hand, money is also a consideration. So let's see if we can bump the salary structure within a modest means that won't get the commissioners too upset. Well, there'll be two of them who vote on the issue anyway. I mean, if we're going to have a board vote, they'll
Dr.
tell you
Fletcher.
whether they're happy with that or not.
If I may, I don't think it's a practical issue of filling this one nurse practitioner spot. I think that can easily be done between Sandy, Eric, and myself. I'm not sure that it needs even subcommittee input. The bigger question is, are we going to have clinical staff going forward? And that's, I guess, really what I'm trying to push the board. Because it's one thing to hire a person, but it's another thing to enthusiastically hire a person knowing that there's going to be a program in place. And I don't know that right now.
Well, how many personnel are you looking? Let's say you get your wish. How high do you want to scale this?
I don't want it scaled largely. I think to start with, and again, I think start with an enthusiastic nurse practitioner that we hire, knowing that there's going to be a clinic going forward would be fine. Followed by a physician that could be in the 2027 budget, because by the time we recruit and hire, it's going to be into 2027 anyway. So I don't think it affects the budgetary.
And you want this now before the next board meeting?
Right.
I mean, what's the timeline of your request?
Today.
Today?
He wants it today. So I think, Greg, I
Yeah,
think it does require our input, not because the position isn't budgeted for, but because of the current paradigm that's existed in hiring that's led to a difficulty of hiring. So we need to kind of work together and brainstorm with all of the people involved so that we have a new approach, so we don't run into the same issue. And so I think there needs to be a discussion and a clarification of a new paradigm if that's what we're wanting. Which
And
I
I
think
appreciate that. Absolutely.
I think we are wanting a new
lot
paradigm.
of discussion.
Yeah.
A lot of discussion.
Yeah.
Except again, there's this practical problem. So just as long as the board understands the risks,
What are the risks?
The risks are that the clinic could close completely.
Right.
If we lose any more staff, the risks are that we don't fix the things that we could be fixing because we don't know whether the clinic's going to exist. I mean, even the exercise of looking at insurance contracts, vendors, costs, materials, so all the vendors.
From my understanding of the communication that seems to be expressed in the room, I think there is a definite willingness to move forward to explore these issues. I don't think that's really the question. I don't know if we need an official vote or not, but I think that the commitment is there to move forward. It's just how. So if it somehow takes a vote, I don't know necessarily that it would need a vote, but I think it's there
I don't
to,
know if we can vote if it's not an action item.
right.
And
So
Chairman, I think that the item to consider here is that we did have an allocated budget for clinical services.
Mhm.
And in the need of aggressive hiring, what you may see in future financial documents is that we've exceeded our personnel budget in that category.
Mhm.
So I think it's more of a heads up of, are you okay with that,
Mhm.
for
Mhm.
the next few months or the next
Mhm.
several months of fiscal year 26?
Mhm.
well, and with just in the medical business, when you hire somebody, they're not going to cover themselves at first, but you have to look at how long does it take me to get a new hire? Is it 3 months, 6 months, 9 months, 12 months by the time you expect them to self-fund and then hopefully generate additional revenue?
Mhm.
And it depends on the position and the experience of the person. So part of it is the additional funding that might be needed should only be needed for a small window of time
Mhm.
in a normal process of someone coming up to speed,
Mhm.
right? So which is something that also in the clarity of the discussion for the commissioners, they would need to know that, because throwing around $500,000 to commissioners is going to get a lot of them just happening. So so I think
I
think
would
that-
be curious to hear from our
Yeah.
commissioners in presence as to what their risk tolerance is.
Well, with hiring another personnel that's already been budgeted for, and you have a little bit of leeway there also because it hasn't been filled. So you have that little bit of, little grace there. So, I'm fine with going forward with that. The physician, that's a different subject. That's a different conversation. So I'll leave it at that.
I agree with you. You guys have the money to hire practitioners.
Right.
You don't have that in the budget. That's what's the issue. But as far as the position goes, that really is something that you guys need to decide, that's really what you want to do. And build that into your budget that you present to your different county commissioners at that time. Because there is, we don't have money just floating around going, oh yeah, here's 700,000 for it. We don't have that. We all know our costs of everything are going up faster than our 3% budgetary allowance to go up. So we're already dealing with that. And then to come and ask for more money for something that has never been discussed around the budget, that's going to be hard getting.
Commissioner Cowles, are you still with us? She was earlier.
No, she has to walk off.
Oh, well, I hear you loud and clear. Speaking only for myself, I would say move ahead. It doesn't seem like we really need a vote on it. Hire a nurse practitioner. And Sandy is nodding her head. It's okay. All right, with a little bit of flexibility to beef up the income to see if we can entice them. But I have to say, I agree with our commissioners in present. I have some apprehension about, getting overboard and hiring and developing a program until we have worked out the details.
I agree.
There are a lot of details. I go back to what Commissioner Matari said to me, bring me a plan. And this has to be vetted not only with your subcommittee, but the finance subcommittee. I mean, we're going to have to get, have to be adult in this. What can we afford? I mean, I can imagine versions of these 9 different programs. Some of them are a lot more cost effective than others. I mean, they're not all the same, and you could still have a robust, meaningful public health presence in the Panhandle and not have an expanded point of service clinical program. Maybe, I don't know. I think there's just a lot of detail here. That's just me speaking. Anyone else want to speak?
Just one thing I wanted to bring up. I think all of us appreciate what Dr. has done. This point, the window of his employment is coming to an end, correct? So
Well, we still have 2 more months. So you're saying, so we
we
need
won't get on the
That's right.
agenda at some point. What,
I'll make you a promise. I'll put it on the schedule, and this is for Dr. Johnson. It will be an action item at the next board meeting.
Okay, thank you very much. I'm sorry.
Did you second the motion to adjourn?
Well, we need another report.
Oh, it's true. I'm sorry. Go ahead. We'll see you later.
Take care. Have a good day.
Mr. Chairman, I have a comment.
Yes,
Question.
sure.
So, in full transparency, we have the funds in the budget as a whole. If an individual were to look at the clinical budget only, we are only under budget by roughly $30,000, $35,000. So I just want to make that clear that the budget as a whole, there is funding for the additional NP. And again, if you were to look at it by line item, clinical for salary and fringe, we would not have the funding, but we're not looking at it at the line item. I just, and I know I'm confusing the issue, but I just want to be fully transparent that as a whole, there is the funding.
Fair enough. Thank you.
And I do have a question.
Yes?
And that question is, with this additional new hire, does that allow us to get back out to the other counties?
The short answer is yes. We are already going back to Boundary County. We are going to the other counties as of now, and would strengthen each of those outlying county presence just by having one more nurse practitioner.
So if we have appointments out there and the clinician needed cancel for whatever reason, that gives us redundancy to honor those scheduled appointments. Is that correct?
I hope so. That's the intention, is that we won't be canceling any appointments. But yeah, absolutely. And I think it absolutely goes to credibility. But again, it's kind of a self-fulfilling prophecy guided by the board, either to go forward with the clinic or not. And it doesn't make sense for any of us to put a lot of effort and resources into clinical matters if that's not the wishes of the board. And I'm sympathetic to that because it's a lot of effort on your part, on Sandy's part, on my part. Yeah.
Chairman Butcher, I think one of the things that I believe you're wanting the go, no go kind of thing. We don't have an action item just procedurally for an official board go, no go. What was that? There is a emergency. There has to be like an emergency. I believe that when I've looked through this before, and there has to be a certain criteria. I don't know if this quite fits it. We probably could force it, but it doesn't quite qualify. So all I have to say is I don't want to hide behind that because that's not what I'm saying. But I'm saying that what you presented is wonderful, but requires a whole lot of, as Dr. Fletcher said, distilling. It's not complete. And so I think that right now we want to keep the clinical services going. And I think we want to figure out how it's in manifestations. I think that because of all the things we talked about, of all the budget, the federally qualified healthcare facilities, their money, who knows where their money's coming from or not. I think it's a great idea. I agree with you that we should keep the clinical services and reform it to some level. I think you presented wonderful thought and processes that we need to now work together on it and figure out what actual is the amalgamation that we want to move forward with. But as far as for hiring a nurse practitioner, I think that's a no-brainer. That's what I was saying because it's also budgeted for. But it's also been positioned, been out there for it. So I think that's where I'd like to meet together and figure out how to.
Well, the position's out there because I haven't actively recruited for it.
Right.
And that's the catch-22.
Yeah. So I would like to, when we meet, we can discuss the active recruiting strategy. So we figure out what we get.
Darla? Yeah, sure.
I think one of the first things you do is start in on some education. Like, nurses are a bunch that want to be out of the and they want to be and a part of it really bad is that we're trying to go in the direction of what the public wants and the public may start to come out if we tell them that we're here.
That, by the way, is spoken by a retired ICU nurse.
In a nurse practitioner.
Right.
Can I, on that point, thank you, Darla, to your point, how do we bring in and because part of this is we need to start bringing in the media management relationship, the voice of mental health. So how do we start to bring that into conversation so that we can then do that?
I think that's a separate question, and it's a really, really good question. It's an important question, but I think it also is a separate question you could spend a whole board meeting on. And we've talked about it internally already, and I think there's some ideas that we've talked about, and we have future meetings scheduled, but I think it deserves board discussion, certainly.
Right, and so maybe we can meet with Eric and start to address that also. But I think the Panhandle seems to have a decent public perception of the environmental services and such, probably your department as well. And I was at another meeting and someone praised how the environmental services at Panhandle Health worked with their permit. So just so you know, there's our people that involved. So I think primarily what we're trying to focus on is the perception of the clinical services aspect of
Absolutely.
health.
My perception of environmental services, they do a great job, and I would leave them alone and let's discuss a clinical
100%. So that's what I'm saying is that we can bring that into our subcommittee meeting and figure that out. So.
And just,
Yes.
Oh.
Oh, I'm sorry.
I defer to
Smart move. Well, I think we're good there. I think we have a green light to hire them. And the subcommittee, medical subcommittee is going to meet next week with these two and figure out salary and also in response to our two nurses in the audience that if the way the package, what your expectations are and how this is going to be different than your typical nursing job. That language, I think, may go a long ways towards improving recruitment. That's the signal I'm hearing from a lot of people in the room. So from my perspective, we're done with that topic. So therefore, you want to move on to something else? Oh, okay. Well, thank you for coming. Did you want to make any final comment?
So I really enjoyed everything. And that was great. A lot about
Commissioner Corn, you wanted to now address a different topic.
I'll come to the big boy
We'll let
table.
you sit at the adult table.
Yeah. Chair's a little low. All right, everybody hear me okay? So I really appreciate the presentation. I got a lot out of it. I know that you put a lot of time and effort and thought into it. It shows. There's a lot of topics there that the general public is very interested in that is not going on right now, such as, well, on your second slide, I think it was, you're talking about maybe monitoring the air quality or for radiation type stuff. I don't know if anybody's doing that right now, but that's a great idea. What is actually being done to keep us healthy, not actually try and help us once we're not healthy anymore. There's a huge movement out there right now across North Idaho and across our nation right now with preventative health care and not just taking a pill after the fact. I don't know if that's something that Panhandle Health could like try and not specialize in, but offer other than the other alternative healthcare doctors and stuff that are out there right now. Maybe be a hub for information to where somebody could come to Panhandle Health and figure out where I need to go for this specific item. It's not my forte, but I do know there's a huge movement out there right now to be able to take care of ourselves, to be able to go through the whole COVID thing like we did in 2020, but actually have a lot more information now and actually have a place to turn to, because we didn't have a place to turn to, and the places that we were able to turn to lied to us. So that's where a lot of the mistrust comes from.
Issue.
Exactly. And it's not just in the health, it's in government across the board. It doesn't matter what government agency it is. There's a huge lack of trust. There was a lot of talk, and there always is a lot of talk about women's health. I'm going to mention men's health. It never gets mentioned, and it's a growing problem, and it's a growing concern. The hormone issues going on with the foods that we eat, with our environment and everything else, it's causing a lot of men's health issues. I would just like to speak up and put that on the radar, and maybe if that could be incorporated, that would be great.
That might go a long ways towards recruiting people to come to your clinic. In other words, if you have ignored half the population, well, then you can't expect them to come. So, amen.
And men don't like to talk about their health issues.
They
I
do.
myself have not been to a doctor for 30 years. Maybe the trust issues, I don't know. But usually when you go to the doctor, they tell you that something's wrong. So I just avoid them. I have nothing wrong.
The
Amazing.
last doctor I saw was my pediatrician when she hired me and final exam when I was 17 years old and went to college. That's the last time I saw a doctor.
Nice. So if there's something that Panhandle Health could do with those couple of issues, I think it would be well received across the board, to help it, to give us some kind of a venue to keep us healthy and not necessarily come see you after the fact.
Commissioner Corn, just so you know, and I'm sure you've heard it before, but the mission statement for Panhandle Health is prevent, protect, and promote. So largely, we are a preventive organization. So I agree with that wholeheartedly. And I also obviously agree with the men's issue as well. There was one slide in the educational part that talked about men's hormonal regulation. I kind of blew past it, but I agree completely.
Thank you.
Okay, any other comments?
If I may just very briefly make a comment, I think as far as to Dr. Pennock's point, is if we had a vision for the clinic, which Dr. Pennock is putting forth, that would also help with recruitment, because anybody that's been paying attention to clinical services at Panhandle Health for the better part of a year has seen the uncertainty on, do we do this? Do we do that? Do we not do anything? And if I was looking for a job, I would be very hesitant to accept a job at an organization that had an uncertain future. So I do, and I realize there's a lot of details to hammer out and that have been put forth. And unfortunately, the timing of this creates a need to do certain things concurrently. Patch the current hole in staffing with clinic, but at the same time have the finance, medical committee, and the budget folks build a consolidated, meaningful plan that can go before the commissioners that they can buy off on or not, and then we adjust the budget accordingly. So I'm all for formulating the final vision.
Well, you stated that well. There is a methodology, and we're going to have to follow it. I think that's what you're saying. Amen. Any other comments? Okay, director's report.
I just have one item. At the board's request, we did, Jessica did set up a meeting with the Region 1 Behavioral Health Board. Jessica, myself, and Kate met with their leadership to discuss better ways that we could collaborate. It was a fairly brief meeting. The suggestions that came forth were that if the board is interested in better understanding what they do, they're more than welcome to attend those meetings. And if they also said if we are addressing any issues that cross into their realm, to please invite them to participate in our meetings as well. So that's a brief summary of that.
So if we went with focus number 8, the opioid settlement, then obviously would collaborate with this group, if that's the direction we want.
Yeah, because
I don't know.
I was researching the group more, and that's primarily what made them come into existence, was the opioid stuff. It looked like on the state level on their website. So at least that's what it says on the website. Yeah. So I think that's part of it would be an important aspect of how we're working together. Consolidate your fire on important topics. You can get farther.
Any other comments? Hearing none, do I hear a motion to adjourn? And Dr. Johnson seconded it in absentia. I heard him. Thank you, everyone. Excellent meeting.
Before it gets dark, oh yeah.
Okay. All right. So, yeah, there is a methodology.